let me introduce two speakers. My pleasure to have one of my colleagues from the CHUV, Enisa Shevroja, which is a medical doctor just working clinical practice also in the Center of Bone Disease in the CHUV. And we have Dr. Karen Hind, which is a director of clinical affairs and working at Medimat, but also have a visiting position at the CHUV. So without getting any further, I will pass it on to start. So one exciting period right now is because IUFHAO, under the auspice of WHO, hold a position development conference on TBS, and they presented the outcome just 2 weeks ago at the World Congress in Barcelona. And the idea is just to have a tips of what has been presented and also see how this can be applied into clinical practice, because Enisa was part of the panel and presents nicely at the World Congress. So Karen, it's all yours. So I can give you access.
Okay, great. So thanks everyone for attending and joining this webinar today. And as Didier explained, we'll be providing an update on the role of trabecular bone score in clinical practice. And to provide some context, I've got a few introductory slides. So trabecular bone score is a validated index of bone microarchitecture, and that is acquired from DEXA. And evidence on the clinical utility of TBS has accumulated for over 1 decade. And this webinar today presents an update on the evidence and the role of TBS in clinical practice. So let's start by looking at the epidemiology of fragility fracture and that burden that is occurring today for both patients and for healthcare systems. In terms of the incidence of fractures, we're seeing 1 fracture occurring every 3 seconds globally. And in terms of the women and men over the age of 50, 1 in 2 women and 1 in 5 men will sustain a fragility fracture. The trends are seeing an increase in the risk of fracture occurrence over time, with a projected increase of 23% by 2030, and by 2040, a projected increase of 44%. Now, equating that to impact, the impact of fracture has a burden both clinically and economically. For the patient, importantly and significantly, fracture brings substantial pain, morbidity, and reduces their independence and confidence. It can really interfere with a person's quality of life. And the first fracture is also indicative of an increased risk of a second fracture. Linking into that as well, with fractures become costs, and the costs to the healthcare systems are, again, substantial. And the data show that per fracture, the cost is around $14,000, and that equates to over $124 billion per year globally. So a huge economic cost, but a huge personal cost to the patient and the patient's family. Now, moving forward and looking at the persisting challenge in the field. And that challenge is that osteoporosis is underdiagnosed and undertreated. And that means that there are patients who need treatment who aren't receiving treatment because the risk assessment hasn't identified them at reaching that threshold. So the real world data that's been published over the last few years indicates that there is a substantial treatment gap in that although anti-osteoporosis therapies can reduce fracture risk by 40 to 70%, unfortunately, the anti-osteoporosis therapies are underutilized. The treatment rates have declined over recent years, and the evidence is now indicating that approximately 75% of individuals at high risk of fracture are not receiving the treatment they need. This presents an opportunity indeed, because we need to do more. We need to improve fracture risk assessment, and we need to improve adherence to treatment. So if we focus on fracture risk assessment, there has been a recent paper published just a couple of weeks ago, which conducted some economic modeling. And that economic modeling demonstrated that if there was an intervention that could improve fracture risk assessment, that had the potential to reduce the cost of fracture by 7%. And although 7% might not seem an awful lot, actually, when you put it into context, that is equivalent to over $1.8 billion of savings annually in Europe alone. The quote from the paper I will share with you today, and that is: the substantial net benefits for example, the reduction in numbers of fractures and cost savings, estimated by our model, support the need for new policy measures and increased efforts to improve the assessment of osteoporotic fracture risk. So there's work to be done. So now we look at the definition of osteoporosis, which most of you will be familiar with. Osteoporosis is a systemic skeletal disease characterized by low bone mass and a microarchitectural deterioration of bone tissue leading to fracture. Now, low bone mass is quantified by DEXA BMD, bone mineral density, and this is equating to a T-score that is equal or less than -2.5. However, the persisting challenge is that approximately half of fragility fractures actually occur in non-osteoporotic patients, which I'll demonstrate in the next slide. Okay, here we go. So the chart here illustrates in the light green the quantity of fractures which occur according to the BMD T-score. And then in the bright blue, you will see the fracture rate. Now, as we can see, the fracture risk increases with decrease in BMD. However, in this zone here, the normal osteopenic zone, we can see that more fractures will occur in this zone. So more individuals in the osteopenic zone will sustain a fracture. And at this point, I'd like to draw your attention to the point that two patients can have the same BMD, but different microarchitecture. Okay, and just to illustrate that a little bit further, here we have an image with some images from two different patients, and these patients have a similar BMD, as you can see from the DEXA bone density images on your left. However, if you look on the right, these patients then received a TBS assessment, and you can see their TBS is different. So the trabecular bone score indicative of bone microarchitecture is different in these two patients. So these two patients were only to have the BMD assessment. We would not be aware of this increased risk in the patient in the bottom of the screen. So with that, we can understand that higher TBS correlates with better bone microarchitecture, whereas the low TBS correlates with the worsening bone microarchitecture, regardless of BMD. So TBS has been used in over 1,000 peer-reviewed publications, and over the last decade, a substantial quantity and critical mass of research and evidence. And it's recommended in over 30 national and international guidelines, a few of those which are shown on the screen here before you. Okay. And as Didier alluded to at the introduction of this webinar, a couple of weeks ago, the 5th of May this year, on behalf of the IOF ESCEO expert working group under the auspices of WHO, there was an update on the strength of the evidence for TBS in clinical practice as part of a dedicated symposium. And in that symposium presented by Eugene McCloskey and also with our colleague Enisa Shevroja, who is on this call today, there was a presentation of the evidence and a presentation of a total of 22 recommendations for the use of TBS in clinical practice. These recommendations were arrived at following systematic review of the critical mass of the evidence and based on a grade methodology. And you can see here a few images of the World Congress of Osteoporosis where the symposium was delivered. You can see in the three slides in the center where the statements were shared. And we don't need to zoom into that because on the next slides, I'll be working through those with a particular focus on the role of TBS in primary osteoporosis for fracture prediction and on treatment. There were also statements made on secondary osteoporosis for fracture treatment, but in this webinar today, we don't have time to go through all of those, but I'm sure we'll be able to provide another webinar in due course with specific reference to secondary osteoporosis. And to verify that all statements here were rated as strongly recommended based on the level of evidence and expert opinion. So here are the primary outcomes of the expert working group in terms of their recommendations, with the first block of recommendations really centering around primary osteoporosis in that TBS predicts fracture independent of BMD and other clinical risk factors, including FRAX. TBS adds predictive value alongside FRAX and or BMD T-score, and the greatest utility is for patients who are close to an intervention threshold. In the second block of recommendations, there was a focus on individual response to treatment, in that TBS is useful for stratifying osteoporosis treatment and for monitoring individual response to treatments. And the evidence for the use of TBS in monitoring response is applicable across both primary and secondary osteoporosis. And then into the block on secondary osteoporosis, it was confirmed that TBS predicts fracture associated with secondary osteoporosis, such as in type 2 diabetes, chronic kidney disease, and in certain rheumatological conditions. And also that TBS adds value when monitoring the skeletal response to aromatase inhibitors and to glucocorticoids. So we'll start with a prediction of fracture in primary osteoporosis, and the recommendation here, which you see before you, is that TBS is predictive of fragility fractures independent of BMD and of clinical risk factors, including those in FRAX. And in this table, you see the evidence base, which has, as I've said, accumulated over more than a decade. And we see within that, the studies that were included were those that were prospective cohort studies, so very high quality studies and well controlled. And in addition to that, evidence from the 2016 McCloskey meta-analysis, individual level meta-analysis, which also provided evidence underpinning this statement. And just to note that the evidence was derived from across multiple ethnicities and in both men and in women. So let's look at FRAX. One of the key statements was that to confirm that TBS adds predictive value to FRAX. And here on the left, you can see how FRAX can be adjusted at different levels of TBS, from low TBS on the left and high TBS to the right. And when TBS is low, you will see that the FRAX score is increased when the adjustment is made, and the effect is greater in younger than in older patients. Now, on the right side, you can see the value of TBS alongside BMD with clinical risk factors. And you can see the risk ratios for hip fracture and other major osteoporotic fractures. And this data is based on data from the 14 independent cohorts that were included in that meta-analysis. Now, the addition of TBS, as you can see in the final column, significantly improved the identification of patients who would then subsequently go on to fracture. So the addition of TBS really did enhance the prediction of fracture. Now, looking at BMD, we can see on the left of the screen, you can see a fracture risk matrix. And the numbers that you see in there are derived from the Manitoba cohort. And the matrix combines both the BMD T-score and the TBS tertile, as you can see in the columns. Now, in this cohort, 16% of osteopenic patients were found to have the same risk of fracture as an osteoporotic patient when TBS was included alongside BMD. So you're identifying more patients then who would benefit from that treatment. Now, on the right side, you will see a chart which demonstrates how femoral neck and lumbar spine BMD T-score can be adjusted for different levels of TBS and the impact that can make on a patient's outcome. Now, a note also to make is that the BMD T-score adjusted, which you see here in the right chart, is actually showing similar effect and ability to predict fracture as the FRAX adjusted for TBS. It's an important point to note. Now, another statement from the expert working group was really clarifying some of the research to date and the evidence to date, in that the greatest utility of TBS is for those individuals whose results are close to an intervention treatment threshold. And on this chart here, you can see data from, again, the Manitoba population published by Martineau et al. And across 3 different treatment thresholds. So you've got the NOF, the Canadian, and the NOG treatment thresholds. TBS was effective in identifying up to an additional 25% of patients for treatment who would otherwise have not received treatment based on BMD alone. And those patients were close to the intervention threshold. Okay, so now we're moving on to treatment. And before we look at the statements, just to provide some context and to draw your attention to the mechanisms of action of different osteoporotic treatments and the expected effects on BMD and bone microarchitecture, which do differ. So osteoporosis treatments differ by mechanism of action and their degree of impact and time frame to alter BMD. And you can see in the chart here the concept of this thinking. So TBS in conjunction with BMD can identify patients at very high risk of fracture and potentially to direct these patients to anabolic first therapies, so based on their microarchitecture and their BMD. Okay, so moving on to the treatment statements from the expert working group. TBS is useful for assessing treatment response. And here we see a summary of the evidence base, so those studies that we used to underpin this statement across bisphosphonates, denosumab, PTH, and romosozumab. And we'll look at this in some more detail in the following slides. Just to note that evidence was also included for secondary osteoporosis, and that TBS was able to detect adverse effects of certain drugs in these conditions. And also 11 studies were found to report preservation or increases in TBS with certain osteoporosis medications. Okay, let's look at bisphosphonates, and these are the results from a recent study, which has been an area of much discussion recently. So here I will address the main question with regards to treatment response to bisphosphonates, menopause hormone therapy, and selective estrogen receptor modulators. Now, if we think about the drug mechanisms of action, we should not be expecting an increase in TBS with these therapies. Indeed, the results from this study showed that in most patients, TBS was unchanged with these therapies as expected, and as aligned with the clinical expectation for this class of treatment. If indeed if you do see patients who have an increase in TBS with bisphosphonates, then it would be a case of this would not be expected, so therefore to look for technical factors or analysis inaccuracies. So taking that logical approach, you can see also that the response from BMD was somewhat disappointing, with only 22% of patients who increased BMD above the LSC, so with these treatments, and quite surprisingly, up to 25% lost BMD under a bisphosphonate. In these patients, again, just as in TBS, technical and clinical factors should be checked. So a statement from the working group was that TBS in conjunction with BMD is useful for monitoring response to long-term denosumab. And here's one of the studies that was included in the evidence base, which demonstrates an improvement in TBS with long-term denosumab to up to 10 years. There's a 4.7% increase in TBS in patients taking denosumab up to 10 years. And we can see in the bottom of the slide here that there was a shift in patients who had TBS in the degraded category and an increase in patients who had TBS in the normal category with denosumab treatment. And that difference was from a proportion of patients in the high risk zone reduced from 49% to 29%, and patients in the normal zone increased from 26% to 53%. So some excellent outcomes there alongside the BMD increases as well. Okay, moving on to PTH. So the working group recommended that TBS in conjunction with BMD is useful for monitoring response to PTH and PTH analogs such as abaloparatide and teriparatide. Here you see an example from the study, the active and active extend study. In the left chart, you can see that changes over 18 and 43 months intervention with abaloparatide and the placebo. And in the right chart, you see the changes in TBS category with the treatments. Green represents patients who were in the intervention, and gray represents patients who were taking the placebo. In the abaloparatide group, 42% of patients had degraded TBS at baseline, but by the end of the intervention, that proportion of patients had reduced to 21%. In this study, there was also an association with a reduced odds of vertebral fracture. with that increase in TBS. Further research will be needed on that, but this is very promising. And equivalent results were also shown for patients with type 2 diabetes. Okay, wrapping this up, we can pull this together and look at the expected effects of TBS and BMD depending on the drug and the class of treatment. On the left, you see expected effects derived from the studies that have been published to date at the population level. And on the right, you can see the individual level results, what would be expected. And this data has, again, been derived from the published studies to date. And the recommendation from the expert working group was that a decrease in TBS more than LSC, so more than the least significant change during a treatment, should prompt further clinical review. So taking that plausible common sense approach to monitoring your patient change. Okay, and that's it for now. It's as much as I could fit in 20 minutes, so I'll hand back over to Didier. Thank you.
Good afternoon, everyone. So I am Enisa Shevroja. I am doing my postdoc, and I am a resident at the Center of Bone Diseases at the University Hospital in Lausanne in Switzerland. I actually have the pleasure to present today to you group work that was done in our center in Lausanne, which was evidence-based, which was led by Professor Didier Hans. As briefly mentioned at the beginning of this presentation of this webinar, this presentation was also made at the IOF and is part of the guidelines of the statements and guidelines, clinical guidelines of IOF 2023. So I will briefly walk you through the clinical approach that we use in our center to actually use so how we incorporate the use of TBS in our clinical practice, in our everyday clinical practice. With the introduction, I will not take time on the introduction because Karen went through everything in details. Basically, it starts from the DEXA acquisition, right? The indications for the DEXA acquisition, of course, depend on the country, but mainly in principle, the indication of assessing the TBS in a DEXA image is same as the indication of having a DEXA exam. In here, at least, we do TBS, we assess TBS for all the patients who have undergone a DEXA imaging, but we assess it especially with, we take great care that it is assessed in patients with type 2 diabetes or who are under anti-aromatase treatment, for example, or with secondary osteoporosis, which are clinical conditions that are known, at which the TBS is known to have particular importance, in addition to the BMD. So once you have, once these patients have had the DEXA images, you want, as a clinician, you want to make sure that this imaging was done properly, and basically you evaluate, you judge if the TBS and the BMDs, in this case in the lumbar spine DEXA image, were properly assessed. Usually the TBS, not usually, but always the TBS is being calculated in the same vertebra as the BMD, usually the same criteria for the exclusion of vertebra, so the fracture vertebra is for BMD are excluded, and we follow the ISCD guidelines for that. It is known that the presence of degenerative changes that do affect the BMD do not affect the TBS. So we know, where we see that the vertebra, the lumbar spine vertebra, are affected by these changes, we do take that into consideration for exclusion of vertebra for the assessment of BMD, but not for the assessment of TBS. And of course that we assess the TBS in cases where minimum 2 vertebrae are to be considered. So once we make sure that the image is of good quality and the TBS and the BMD of this image are properly assessed and calculated, we extract what we can extract from this image, right? So what we can extract from the DEXA images is the BMD values, the TBS values, and the information whether there is or not a vertebral fracture in the VFA image. Once we have this this information, eventually, like the question of how bone health of this patient comes up, and what is the risk of this patient to have a fracture, a first fracture, or another fracture if they already had one. How we do it, like how we assess the overall bone health of this patient, how we quantify this bone health is by calculating the BMD, the TBS adjusted BMDT score. As Karen mentioned this at her presentation, this is based on the study of Leslie at the Manitoba cohort in 2018. So first thing, we calculate this score, TBS adjusted BMDT score, which takes into consideration the information that comes from the value of the BMD and the value of the TBS. Next step is to quantify the risk of having a fracture for this patient, which depends again on the country, but in Switzerland, we do it by calculating the risk by FRAX, by using the Swiss FRAX model. We, given that we have both the value of BMD and TBS, we adjust the FRAX value, value for the BMD and the TBS. We can pass to the next slide. So once we have the information, so we have an overall score that gives us information on the BMD, on the bone density of this patient, and on the TBS, on the microarchitecture of this patient, which is the TBS adjusted BMDT score. And we have the information of the risk that this patient has to have future fracture, a fracture in the 10 years, more specifically, as measured by FRAX. Clinically, we have to think, that's why the patients come, to know if they need treatment or not, and if yes, which kind of treatment. How we make the decision if we should treat the patient or not, again, this is country specific, but in Switzerland, we base it on the value of the BMD, of the TBS adjusted BMDT score, and we say if it is lower than minus 2.5, we have to treat. So it is we have an indication to treat this patient. And if the risk of this patient to have, if the risk adjusted for BMD and TBS of this patient to have a fracture in the next years is high, we also have the indication to treat this patient. And of course, we all agree that, we start from there, that if the patient has already had the fragility fracture and typical osteoporotic fractures, of course, we have the absolute indication to start the treatment. Once we have made the decision that we should treat this patient, we should start to discuss with the patient of the treatment that we propose them. That we propose to them. Conceptually, how we think of the treatment, we have two choices: anabolics, bone so medications that form bone, and anti-resorptive medications that stop the bone resorption. Conceptually, the TBS, as Karen mentioned as well, the TBS is more impacted by medications that form bone, anabolics, such as romosozumab, or teriparatide. And for when we make this decision and when we propose the treatment to the patient, we keep that in mind. What is the goal of the treatment that we want to start for this patient? Do we want to improve BMD, TBS, because also TBS is of poor value or not? And the length of the treatment, of course, it depends on where you start. It depends on the stage where you start the treatment at. If you like the ending goal of the treatment, of why you want to treat a patient, is to lower their risk zone. So conceptually, as I mentioned before, you want to improve what can be improved. So the bone parameters that can be improved. You cannot improve age, for example. So that is the goal. So you choose a treatment that can improve what is already degraded. Okay, thank you. Of course, that we should keep in mind that when we follow a patient when we do the follow-up of a patient under treatment, we should keep in mind we basically do a DEXA every 2 years classically, but when we give, for example, romosozumab, we do the DEXA every year. And we should keep in mind that the interpretation of the changes of the evolution of the BMD values and equally of the TBS values should be made based on the LSC values, which are specific for each center and of each center. So that we keep in mind always. And the change, of course, the evolution of both depends on the mechanism of action of the drugs. As I mentioned, the anabolics are expected to be more impactful to both BMD and TBS. This is actually just to visualize what I already walked you through. This is actually how the report that we provide to the patients and to the family doctors from the DEXA exam that they do in our center looks like. So we start by stating if there is a fracture from the VFA images or not. Then we provide the measures of BMD and TBS. Then we provide the value of what I mentioned of the TBS adjusted BMDT score. Then at which risk zone the patient is based on the TBS value and BMD value is. So this is the table with the colors. And also we provide the risk of having a fracture is based by FRAX measures. And the diagnostic, we make the diagnosis based on the, as I mentioned, adjusted BMDT score. And yeah, so this is how it looks like. Thank you. I haven't forgotten anything to mention from the report. Thank you very much for your attention. Happy to receive your questions.
Thank you very much, Enisa. And I can just really just take maybe the first question here, and I will try to answer. So one of the first question is, ICD recommend to use the TBS as a complement for FRAX, not isolately. Thus, what is important of classifying as TBS 1, 2, 3 category? And if so, which will be the cutoff? I understand ICD recommend to use complement of FRAX, not isolately, but in the same token, is like having the BMDT score as normal osteopathic osteoporotic, and you still enter that value into the FRAX. So I think it's always important for the discussion with your patient to know what's going on, and just giving a FRAX probability It tells you your level of risk. It doesn't give you the etiology of the risk, meaning, are you at a high risk because of clinical risk factor? Are you at high risk because you have a low density or because you have a low structure? And having different be able to explain that with the patient is quite important. Moreover, depending on the guidelines, some people don't use FRAX, and in that case, it's important to know again in which category of risk you hand it up. So the cutoff value for the TBS as a category for L1, L4 usually is 131 and 123. Above 131, it will be characterized as compatible with a normal structure. Between 131 and 123 as a partially degradated, and below 123, a degraded microstructure. Now, having said that, if you exclude the vertebrae, the value may change upward or downward, but the TBS software will automatically adjust the threshold for you in the algorithm. So that's something you will have to take into account. So I don't know if that answers your question, or if Karen or Enisa want to add on that.
No, you covered everything, Didier. Very good.
Okay, so there is another question here. The question is why we will not expect a change in TBS with biphosphonate. I think it was nicely said in the presentation by Karen. When you have the balance between formation and resorption, biphosphonate will mostly increase the degree of mineralization, meaning that will increase the microstructure of the bone. That will increase by the increase in the degree of mineralization. You will increase the mineralization, fill up the cavity, and increase the density, but that will not have an impact on the microstructure, so to speak. So this is a well-known that was already described by Hind and so on in 1994 at the early beginning of biphosphonate. So we will not expect to have a major increase in biphosphonate. So obviously, by increase the degree of mineralization, you may fill up some cavity, and some of the may have a small impact on microstructure because a hole might be filled, and that will have minimum impact, but we're not expecting to see a major impact because the formation resorption is not in a positive balance for the formation. Question, adding TBS to BMD clinical risk factors improve fracture patient discrimination. What's happened if BMD is really low, but TBS, Z-scores +1, order +2? How to deal with this in a clinical practice?
Where it makes a clinical difference, like a clinical impact, the TBS is when in the osteopenic patients, if a patient with an osteopenic value of BMD has a low TBS, then the risk of this patient to fracture is similar to the risk of a patient with osteoporotic values of BMD. So that it makes a meaningful difference. In the case that you mentioned, again, in our clinical practice, we take into consideration the TBS adjusted BMD score. So we do adjust this low T-score, as you mentioned, by the TBS, by the good TBS value. But what we see is that it does not make a difference because the formulas themselves were already based on this concept.
Yeah, maybe also in other cases, sometimes you have cases in osteomalacia where the density, the degree of mineralization maybe looks low, and then it will not have a density, so to speak. So the density will be very low in case of osteomalacia, but the structure itself is still there. It's just only related to the degree of mineralization. So that's one of the cases where you have very low and high TBS. But it's true that you have more often the opposite, where you have a high BMD because it will be impacted by osteophyte, or it could be in case of type 2 diabetes where where the glycemic control is not controlled. In that case, the BMD will be normal or supranormal, while the TBS, especially if the HbA1c is below 7.5, then the structure will be normal. If it's above 7.5, in that case, you will have a degraded structure. So that will be more in that side, but obviously it's also happening in some disease, or in case for osteolysis, or in case for laminectomy, some of the case where we can have some impact and you measure the same region of interest. So please define degraded TBS, which total number or Z-score is mean. Why do you give a T-score? Well, that's what we refer to the previous question where we talk about degraded with a threshold of 1.23 and below, except when it excludes vertebrae, keeping in mind that L1 tend to be lower than L2, which is lower than L3, and L4 tend to be higher. So exactly like the BMD, except the BMD, when we use a T-score, we just normalize that. So at one point, we could have normalized things for the T-score, even for TBS, but the problem is when you start to use T-score, people get confused with osteopenia and osteoporotic. And I remind you that the T-score definition of -2.5, -1 is only for certain skeletal site and technology with a BMD. So that was just probably to avoid confusion, but maybe another way will come down the road. Oh, I have a question here, which is how well used is TBS in UK? Well, Karen, you're from UK, so maybe
yeah,
you
I can provide
comment on
some
that.
insights just briefly. So I think what we're seeing in the UK is an increase in the use of TBS in clinical practice. I don't have exact figures, but we're seeing that the awareness is growing and the recognition of the added value there. And also actually the Royal Osteoporosis Society published a really nice article on the use of TBS in a UK clinic, and I think that was a nice resource. It was just published, I think, in their quarterly magazine a couple of months ago. I think it was the January edition. So if you're a member of the ROS, then please check that out. But it was a nice article. If you don't have access, just let me know, and I can maybe send that to you.
Here, there's another question. Can you please give an assumption? What is the LSC for the TBS? I think that's an easy one to answer. Karen, I think at one point,
easy.
and the same with Enisa. Or Enisa, you work on some papers for the working group. So I don't know. I don't know if you recall, or Karen. I know you're also working on a review. So.
Well, precision is a big topic of mine, as you may know. I'm really interested in the foundations and methodology of medical devices. And what I can tell you is that with TBS precision and LSC, very, very similar to BMD. There's a number of studies out there which demonstrate that in different cohorts and across both the GE and hologic systems as well. So you can be confident in the ability of being able to detect the least significant change. It lies around about 3.7% if we look at an average across all of the studies. I think conservatively, we may suggest a 4.1%, I think, in the reports, but generally equivalent to BMD, precision error, and LSC.
Yeah, thank you. So is around 1.49 niche or something like that?
Yeah,
that's
the actual
average from different study. Yeah, that's what the question. What is the average LSC? Then you will see from literature.
Yeah, so the average precision error is around about 1.39, 1.4% coefficient of variation, and that equates to an LSC of around 3.7%. So yes, similar to BMD.
Is it based on one study or multiple studies?
No, multiple studies. So part of my review, which I've been conducting in terms of the precision of the software, has demonstrated, I think it's about 12 or 13 studies. There could be more, and that's the average. So you can have confidence in that. But what just a disclaimer there, if ideally it is recommended that the LSC is center specific.
Yeah, so we have a question from Larry. Hi, Larry. Would you ever expect a patient on anabolic therapy to show improvement in TBS greater than its LSC and not similar increase in BMD by DEXA? I think that was, you demonstrate that through the studies. that you have like a population base and individual level. So maybe you can comment that again, Karen,
I
because
certainly
maybe
will.
Larry didn't was.
Yeah, I maybe
not at that
speeded up
time.
towards those final slides, being conscious of time. So apologies for that. But what I can say is that if you do have a clinical scenario where this happens and you see an increase in TBS, but you don't see any increase in BMD with an anabolic therapy, then alarm bells should be raised, and you need to explore that and see what potentially could be the reason for that. And it's a case of looking at those clinical factors and potentially technical factors as well. But that would be an unexpected outcome. You would really expect patients to have an increase in BMD with an anabolic therapy. I think it'd be unusual to not see that. So it'd be to do some further explanation.
Yeah. We have a quick question from Lanny Simpson. Please explain the mechanism that you believe increased TBS in long-term denosumab. So I'm not quite sure what to go there, but just, you know, again, from the little graph that Karen showed at one point is between the ratio resorption formation. The denosumab would clearly block the resorption and maybe less compared to more than compared to bisphosphonate. So the ratio formation resorption still have a residual formation things that will be as a net balance can explain the little improvement that we see on teriparatide, on denosumab, long-term denosumab. Now, keeping in mind that this at one point come to a plateau, which means that we will not increase as like BMD up to 20%, that will start to flattening around 5 or 6%, where you reach pretty much the maximum you can have here with long-term things here. Here question, like a G user. As far as I know, there is no automatic calculation of a TBS corrected BMD, at least on G Luna. Why? The answer is they do. On the SP5 release or whatever, it's just a matter of the software release that you have. And I know that they were having some difficulty at one point, but since now about 2-3 months, they are updating the client with the latest software. And in the latest version, which is 3.1 version from the TBS standpoint, even embedded in the G Luna Encore software, there is a BMD score adjusted by TBS. So another question from Carrie is, how is the BMD score adjusted calculated? I work with Bill on the paper and the other group. We use a similar approach that we use for FRAX, is when you combine the BMD and the TBS, what is the added value you add in terms of fracture risk reduction, increased fracture risk, and so on. And when you know the offset of risk, then you just go backward and have an equivalent of what should be then the BMD score to reach the equivalent level of the offset risk. And then you just feed that back into the BMD model, and that you have the BMD score adjusted. So that's fairly simple. And what was also very interesting is because we have a lot of people then potentially can say, oh, maybe we have no FRAX, but we have another FRAX like model. In that case, you can even enter the BMD score adjusted by TBS into the FRAX-like model. And that can take into account the structure through the BMD, which is quite nice. Okay, there is another question. Many thanks. If in my center we already have TBS and DEXA, of course, what is the residual function of FRAX, taking into account the underestimation of many patients that we see every day with this score?
I can maybe just jump in with that, and really you need to be, you would never use the TBS alone. The FRAX will always have clinical value and accounts for numerous different clinical risk factors, and that adjustment with TBS really puts it all together. So yes, if the question is about the utility of FRAX, then indeed you would continue to use FRAX, and it's the adjustment with the TBS. You'd never use TBS alone, if that was the question.
And if not, maybe Jose, you can just rephrase the question underneath and then come back on that, if I can manage in the next 4 minutes to cover that. So what about young ages with low BMD as low Z-score? Is TBS applicable for this category? Well, it depends on what you mean by young ages. So first of all, the BMD T-score adjusted by TBS is only used in T-score, so which means the software will block the adjustment if it's below the age of 50. Otherwise, you start to have incoherence at the lower age. Now, if you're talking about young age, like lower than the age of 20, at the moment, the TBS software is not being optimized, and it's not supposed to be used for young adult below the age of 20. So the newest version that will come at the end of this year, and it will be more applicable to younger age, and there will be current mid 2024. There will be a claim being submitted to the FDA for use in pediatric using a BMD T-score adjusted for tissue thickness that be applicable for children. And actually, already nice group in US been published with using the new algorithm reference curve with the new algorithm. And so we start to have nice data with the new algorithm, but it's not been FDA cleared for clinical use. Another question, can you comment on DMAB, improved microstructure? Already answered from another one. Do I need to take medicine if my TBS is in normal range?
So to get there to assessing TBS, you probably had a story behind. So you probably had the reasons why you did the DEXA and why you assessed the TBS on the DEXA. So it depends a lot on your anamnesis, on your clinical history, and it depends also a lot on the whole information that you get from the DEXA, on the BMD, on the presence of vertebral fractures, and of course on the TBS value as well. But it doesn't come alone as a decision on only based on the TBS.
Yeah, you really never make a decision on one single parameter. It's a clinical context and a holistic approach with different clinical risk factors, BMD, TBS, biomarkers, sometimes VEGF, and so on. So you're not deciding not to treat just because TBS is normal, because the level of risk, you have a normal BMD, a normal TBS, and osteoporotic BMD, your level of risk is very high. So don't forget that you're estimating a certain level of risk, which is multifactorial. So will FRAX 2.0 will integrate into the software for fracture risk calculation? I know that TBS, so there was some presentation about the FRAX Plus or something like that at the World Congress, and the FRAX, the TBS will be part of the FRAX Plus or FRAX 2.0 that is indeed integrated in the new risk FRAX calculator.
We have reached the end of the session. So thank you very much for joining and for your questions, for your interactions, and for those who are listening in the future as well. Thank you to Enisa and also to Didier. And I think Didier, your slide might be back on.
Thank you everyone for following.
Thanks, Enisa. Great job.
Thank you, Karen.
Thank you. Thank you, everyone, and good day or good evening.